Once patients have an understanding of the root cause of their infertility, doctors can offer a variety of treatment options to address a patient's individual needs. With more on conditions affecting fertility, here is Dr. Randall Craig.
One of the main reasons people come see us here at the Fertility Treatment Center is because they're having trouble getting pregnant, and they're in the older age group. Older age group in reproductive science means you're in your late 30s or early 40s, and that's actually the bulk of the patients we have here are in that age group. For women in that age group, their chance of getting pregnant depends on two hormone levels. The first hormone is FSH, the second is AMH. FSH stands for follicle stimulating hormone. It tells you in general about how many good eggs are left in the ovaries. The AMH in general tells you how much time you have left to get pregnant. In other words, how much time is left in the biological clock. For instance, a woman may have plenty of eggs, but she's running very short on time. Or she may have lots of time, but may be running short on eggs. One of the first things I do here for patients who come in over age 35 is to run an AMH and an FSH level. Then when I get those results back, that lets me know pretty well what to tell the patient in terms of how to plan getting pregnant. If you're running short of time, we speed things up and go to higher level options faster than we would otherwise. But there's plenty of eggs and plenty of time. We get to start off with lower cost, less technology levels and work our way up if we have to. This way we can maximize the total chance of pregnancy for the lowest overall cost. Now, one of the more common reasons for failure to achieve pregnancy in women is blocked fallopian tubes. And this is probably the second or third most common reason that I find in my practice that women are having trouble getting pregnant. Most of the time, the tubes are not truly blocked. They just have mucus plugs built up in the first part of the tube. This is quite common, especially if their hormones are slightly out of balance. It gums up the mucus, and now sperm and eggs have trouble getting back and forth through the fallopian tube. The way to get around this and the way to treat it is to do a procedure called hysterosalpingogram X-ray. Its abbreviation is HSG X-ray. This is where I run X-ray dye into the uterus, and it goes out the fallopian tubes and clears out the mucus plugs. So the X-ray is actually two different types of tests. A diagnostic test to find out if the tubes are truly blocked or if there's a polyp inside the uterus or something down those lines. It's also a therapy. When I run the right type of X-ray dye through the tubes, I clear out the mucus plugs. That alone will triple your pregnancy rate for up to 3 months afterwards and double it for 3 or 4 months after that. It's as good or better than most fertility drugs. Once in a while I find a fallopian tube that doesn't clear very well with the X-ray. If that's the point, if I find that, I get a gadget called a Novi catheter out right then and there during the X-ray. I can now feed that up into the fallopian tube, and I can usually get the tube cleared out with this particular gadget. And that way, that avoids the patient having to come back and do a surgery later to try to replace a fallopian tube or take out a bagged section. Instead of doing an expensive surgery or doing an expensive runaround with in vitro fertilization, I can get the tubes open on the spot at least 70% of the time. So this saves the patients a lot of trouble and money. If they have a blocked tube, I can usually get it working at the time of the X-ray. And that way I can triple their pregnancy rate for the next several months, and most patients get pregnant first, second, or third month after the X-ray. About half the time when a couple have trouble getting pregnant, it's due to male factor. In other words, a low sperm count or low sperm motility, or simply due to the fact that the husband has had a vasectomy. I see a lot of couples here who are, for instance, on a second marriage, and he's had a vasectomy, they still want to have children. There are two ways to have kids after vasectomy. One is to go ahead and have a surgeon reverse the vasectomy with a surgical procedure. The other method is to go ahead and tap sperm with a needle and then use that sperm to fertilize eggs with in vitro fertilization. That has a very high success rate, and it saves the trouble of going through a reversal surgery. I would say the second most common reason that couples have trouble getting pregnant is due to a female condition called polycystic ovary syndrome. It's quite common. About 8% of women in the country have this syndrome. It's the second most common known medical syndrome after low thyroid. And what it means is the woman has irregular periods, she builds up small cysts on the ovaries, her hormones go out of balance. And this is probably the most common hormonal reason for trouble to achieve pregnancy. There are actually 4 types of polycystic ovary syndrome. The first type is the most common. It means that the woman's insulin level is too high. In a way, this is the opposite of diabetes. If you're diabetic, your insulin level is too low, you have to have an insulin shot. If you have PCO type 1, that means your insulin level is too high. High insulin makes it easy to gain weight, hard to lose weight. You get tired and sleepy after meals and carbohydrates, hypoglycemia, and you have trouble ovulating. We have several methods to achieve pregnancy with this particular syndrome. Low-level fertility drugs that are very inexpensive and have minimal or no side effects, all the way up to surgical procedures. We can also block the high insulin with medications. When we do that, a lot of our women lose anywhere from 7 to 20 pounds without even trying. They ovulate much better, they have a high pregnancy rate and a low miscarriage rate. The second type of polycystic ovary syndrome is called type 2 atypical. These women are not overweight, they tend to be tall and thin, but they have irregular periods and polycystic ovaries, and their hormone imbalance is even worse than type 1. There are some inexpensive medications which will rebalance these hormones. They have regular periods like clockwork, they ovulate like clockwork, and they get pregnant fairly easily. The third and fourth types of polycystic ovary syndrome are relatively rare. They are adrenal-based, but we do see these patients once in a while. One is called CAH21, where one of the enzymes in the adrenal gland is partly missing. Low-dose medications such as dexamethasone will correct that imbalance very nicely. These people also lose weight, ovulate on a regular basis, and get pregnant relatively easily. The least common is the type 16 CAH. I see it once in a rare while. It's very much like the other adrenal gland hormones, but it's associated with high blood pressure. Response to the same medications, if I put them on basic medications, they have clockwork periods, ovulate, and get pregnant with relative ease.